The message this morning is risk stratification. I think we've heard that from both our speakers. And I can't think of a better third speaker to introduce than Dr. Parker from the Marsden Hospital. He's down here to talk about active surveillance. But I know his plans are perhaps slightly broader than that, and he intends for us to be using the vote pads that you have there.
So I spoke about active surveillance at this first masterclass a couple of years ago, and so rather than repeat anything, should I use that? Rather, I'll give an update of what's happened since then in surveillance, and then I'll tackle 4 issues or questions which you raised in feedback to the last session, which are listed there. So first of all, an update on what's new in active surveillance. But before I get to that, an interactive question. So before I start, how confident are you about active surveillance? Don't think about it for long. What's your gut feeling? Are you happy it's safe, no problems? Or really, deep down, are you a bit anxious that your men might come to grief if they start out on surveillance? So I think you're voting now. Do we know when voting's finished?
Yes, it's up behind you for 6 seconds. 4, 3, 2.
Okay, let's see the answers.
No one's very worried.
Well, let's show you the data. So, the most important new data on surveillance comes from Toronto. So Laurie Klotz in Toronto is perhaps the father of active surveillance, and just this year he's updated his results. And what you can see is that they're not very selective. So there's a significant proportion of men with relatively high PSAs and also with Gleason scores of 7. So it's a fairly broad range of patients. Now the study has included 450 altogether, of whom 135 have been treated so far. I just highlighted the reasons why those men have been treated. So most because of the rate of rise of their PSA, but a significant proportion because of what was found on repeat biopsy. And I mention that because I think some people in the UK don't do the repeat biopsies. If you do them, you will find high-grade disease. Now, Laurie's data does provide the critics of surveillance some ammunition, if you like. And so here you see the results in terms of PSA control after treatment in those 135 men who were treated. And they're not very good. So of those who've been treated, around half of them have recurred subsequently. And so if you don't believe in surveillance, you might look at this data and say, delaying treatment is not a good idea. Now, I don't say that. I mean, imagine you've got 100 low-risk men, and you treat them all immediately, and you cure 90% of them and 10% recur, which is entirely plausible. Supposing then you take those same 100 men, and instead of treating them immediately, you put them all on surveillance, and only treat the worst 20. Now clearly, half of those 20 will recur, at the least. You get a 50% failure rate. That doesn't mean to say surveillance is a bad thing. If that were the case, it would mean surveillance was entirely safe. So I'm actually encouraged when I see this result, because it suggests to me they're selecting the right men to treat. If they only had a 10% failure rate, I'd be worried. The other reassuring aspect of their data is the long-term survival. So on the top you see overall survival, and on the bottom you see prostate cancer specific survival. And the prostate cancer specific survival is 97% at 10 years. But of course men have a habit of dying of other things in their 70s and 80s. And another way of showing that same data, which I quite like, is this. So here you see the death rate from prostate cancer, which is around about 2% at 10 years. And this is the relative risk of dying from something else other than prostate cancer if you were aged less than 70 when you started surveillance, or aged more than 70 when you started surveillance. So So for men over 70, they appear to be 30 times more likely to die of something else other than prostate cancer if they go on surveillance. And for men under 70, 9 times, according to Laurie Klotz's data. So I find that quite reassuring. Similar data, this is from Rotterdam. So they've also got long-term outcome data of many men, and you can see the overall survival and the prostate cancer-specific survival. That jump in prostate cancer-specific survival at 12 years, that's one death, that's one man. And this table just reminded me to say they got 577 men on surveillance, of whom 53 have died from something other than prostate cancer, and 1 has died from prostate cancer. And then our own data from the Marsden, we've got 480 men put on surveillance over the last 10 years, and we've treated around about a quarter of them. A small number have gone on to watchful waiting. 16 of them have died from other causes, none have died from prostate cancer. We have got 1 man with hormone-resistant metastatic disease, so clearly he will die from prostate cancer, and then the majority are on surveillance. So that's an update, that's what we know about surveillance at the moment. So just vote again. How confident are you now? More confident? Less confident? More worried? I'm pretty confident myself. Let's see what you say. Ooh, yeah, so you're more confident than you were. Still some reservations, so let's tackle those. So first of all, what do patients think about surveillance? That's a question that you asked last time. And of course, everyone's different, so one can't really generalise. There's one bit of data that we collected, and we had a psychology PhD student who gave various questionnaires to a large number, more than 100, of men on surveillance, and men who are going through radiotherapy for prostate cancer, and men who are being followed up years after radiotherapy, in order to measure their anxiety and depression. And there was absolutely no difference between them. So men on surveillance were no more or no less anxious than other men with prostate cancer. And I thought I'd give you one story which illustrates how an individual man changes over time. So this chap was young, just 51, when he was diagnosed 6 years ago with low-risk prostate cancer. He was an intelligent man, a local government official. And when he was first diagnosed, I wrote in the notes, he's not finding it easy to cope with the thought of being on surveillance, and he actually went to see a psychologist. And then, interestingly and unusually, 6 months later he came along with his teenage daughter. And what he said was that he was okay with surveillance then, but she wasn't. She was really worried that her dad had cancer that was not being treated. And he wanted me to give her the rationale for surveillance. Anyway, as time has gone on, he's become completely laid back about it. So he now has presented the patient's view at meetings like this about surveillance. And in last year's Christmas card, he wrote, "All is well. It's 5 years, and much to be thankful for." So it just illustrates how short-term anxiety doesn't necessarily translate into long-term anxiety. So that's all I was going to say about what patients think about it. Another question that you put, when does active surveillance become watchful waiting? Which I think is a good question. Just to clarify, so that we all know what we're talking about, by watchful waiting, I mean observation, keeping palliative treatment, usually hormone therapy, for men who develop symptoms from progressive prostate cancer. Whereas by surveillance, I mean monitoring with blood tests, biopsies, MRI, keeping radical curative treatment for those who we think might need it, even though they're entirely asymptomatic. Now, if surveillance all goes well, there'll come a time when curative treatment is no longer appropriate, simply because someone's so old or decrepit, it's just irrelevant. And that becomes watchful waiting. You're not that decrepit, are you, John? You're chuckling there.
So you discharge them, do you?
Now, when does that happen? When does somebody on surveillance say he's actually on watchful waiting? And I don't think there's any easy answer to that. I think it depends on their comorbidities. So if someone develops, for example, metastatic renal cancer, obviously their surveillance should end and they should be on watchful waiting. Very often it's not as clear-cut as that. I have to say, in my mind, as a sort of rule of thumb, when someone gets to their 80th birthday, I often think about changing them to watchful waiting. But I would discuss it with them. You've been on surveillance for so many years, we've been doing all these biopsies. There'll come a time when we switch you onto watchful waiting and we discuss when that should be. So it's a sort of mutually shared decision. But the patient's values are very important, and that's illustrated by this case. So this was a 73-year-old man diagnosed 10 years ago with intermediate risk prostate cancer. He had type 2 diabetes, he had high blood pressure. He started off with a PSA of around about 13 or 14. He chose to go onto active surveillance, and a couple of years later, his PSA had risen significantly. And so I sat down with him and said, "You've got a significant cancer, you should have it treated," and I advised him to have radical radiotherapy. He refused, he declined that, and therefore he changed to watchful waiting because of his own values, not because of his life expectancy or comorbidities. That's what he wanted. And as it happens, 8 years on, he was right, because he's still no problems from the prostate cancer. And his PSA is now up to 35. And I suppose, actually, whether he's right or not depends what happens in the long run. Is he going to outlive his prostate cancer? Is his prostate cancer going to cause him problems? And that remains to be seen. But that was his values determining the change from surveillance to watchful waiting. Now, I'm only briefly going to touch on MRI, very briefly, but to give you a story of a patient for whom MRI was helpful as part of his surveillance. So this was a man in his 50s who was diagnosed 5 years ago with small volume, low-grade prostate cancer, PSA of 3. He had a repeat biopsy 3 years later, very similar findings. You can see what his PSA has done over the last 5 years, absolutely nothing. Now, those dates, that's from 2005 to 2010. And this was his MRI most recently, which suggested an anterior tumour. And so in spite of the fact that his PSA kinetics were completely flat, in spite of his previous negative transrectal biopsies, we did transperineal biopsies, and there was extensive involvement with prostate cancer, Gleason 3+3. And so he went on to have treatment. So that's a story of how MRI helped this particular man. We've also got a bit of data. So here's around about 80 or 90 of our men on active surveillance, all of whom had diffusion-weighted MRI prior to their repeat biopsy. And this is the ADC that Claire talked about, looking at cellular packing. And these are the guys with favourable diffusion-weighted MRI with high ADC values, and none of those had high Gleason scores or extensive disease on the repeat biopsies. And then these are the men with the adverse diffusion-weighted MRI, of whom a significant proportion were upgraded on repeat biopsy. Now these men here, do they have nasty cancers or not? Maybe they do and they were missed on the biopsy, we just don't know. I guess time will tell. So my feeling about MRI is that it is really useful. So I have a strong hunch that it's really useful, and certainly all our surveillance patients get an MRI at baseline now, and all of them get repeat MRIs every 2 years. Can I prove that it's worthwhile and a good thing? No, not yet. But if I was on surveillance, I would definitely want MRI. And then, what about the role of template biopsies in surveillance specifically? Well, there's no doubt that if we did them, we'd find a whole lot more cancer. So this Gary Onek has presented data on 100 men, all of whom had low-risk prostate cancer and were deemed suitable for surveillance. And he did a transperineal template mapping biopsy, 5mm intervals on all of them, and found Gleason 7 disease or more in a quarter. And he advised them, therefore, not to have surveillance. So it would change what we did. But I do have a number of reservations. I mean, it certainly makes sense insofar as you would have a much better idea of how much cancer is there and what grade it is. The big difficulty I have is I don't know what you do with that information. So if you know that somebody has 1 millimetre of Gleason 3 cancer, okay, that's easy. They're great for observation. Don't need to worry about them. And similarly, if you've got 10 millimetres of Gleason 8, that's easy. They should have treatment. But I have no idea where you should draw the line. And I don't think anybody else has either. We just don't know. It's a complete mystery. And what I would say is that if MRI turns out to be as good as we think it is, then we won't need to do template biopsies. Claire will tell us how big the cancers are and how nasty they are. But in the meantime, I am using it for selected men. So I particularly use it if we think they might have an anterior tumour on their MRI, or if we see something on MRI which we think might have been missed elsewhere. So here's another male on surveillance. Once again, low-risk prostate cancer. Fitted well, went on to surveillance. This is what happened to his PSA over the last 5 years. Huge fluctuations, really making it rather difficult to interpret. And that's not unusual with men on surveillance, which is one of my reservations about using rate of rise of PSA. And this is his MRI, which was, he has serial MRIs every 2 years. And on the latest one, it was reported as showing a possible tumour at the right apex measuring about 10 millimetres in diameter. And so therefore, I sent him to Mark Emberton for transperineal template mapping biopsies, which confirmed he had very, very small, 2 millimetres of 1 out of 40 cores. So for him, I think that was useful. He carries on with surveillance, reassured. Time will tell. And then the last question which you raised last time was, could I be more precise about who is eligible and who isn't eligible for surveillance? And could I be more specific about when you're on surveillance, who should be treated and who shouldn't? Well, before we go any further, this is the chap I just mentioned a moment ago. I've got an interactive question for you. How suitable do you think he is for surveillance, based on what you see on the slide? Do you think he's absolutely perfect for surveillance in every way? Do you think it's completely out of the question, should have treatment straight away, or somewhere in between? So he's fairly young, 59, T1, Gleason 6, small volume, 1 out of 17 cores, fairly large gland, completely fit and well. What do you think? Right, yeah, pretty suitable, yeah. I would say he's just about perfect. I can't imagine somebody more suited to surveillance on the information presented there. Now, this is my starting point for who's eligible for surveillance and who isn't. And that is, it's a man who regards the risks of treatment to outweigh the benefits. He doesn't want treatment now. But he's got an open mind. So if, in the future, we find out more about his cancer, turns out it's a bit worse than we thought, he would be prepared to have treatment. So that man, by definition in my book, is eligible for surveillance. And conversely, he's not eligible for surveillance if he thinks the benefits of treatment now outweigh the risks. And I think this is exactly the same whether you're dealing with somebody who's just been diagnosed and they're trying to decide what to do, or you're dealing with somebody a couple of years down the line who's on surveillance. It's the same question in my book. And do the risks outweigh the benefits? Now, I realise that's not specific. So what can I say in terms of specifics? I would say that the most important factors at the moment in determining who's eligible and who isn't, and in determining who should have treatment at a later date, is Gleason score and life expectancy. Now I say that to a large extent on the basis of the SPCG4 trial. So it's the only randomised trial we've got at the moment comparing curative treatment versus watchful waiting, not surveillance, watchful waiting, which showed an advantage for treatment, as we all know, for surgery. But what I think is interesting is the subgroup analysis. So across the board, there was about a 7 percentage point improvement in overall survival for surgery versus watchful waiting. And what this shows, or what this suggests, because it's a subgroup analysis, is that the advantage for surgery is significantly greater for those men with Gleason 7 and above than it was for those men with Gleason 6. And similarly, the advantage is much greater for young men rather than older men. And whilst it's not cast iron, it's not proof, I think it's very suggestive that the men who stand to benefit most from treatment are the men with higher grade disease who are younger. And I think those factors are the most useful. In my book, PSA kinetics are less useful. I would perhaps say much less useful. Now we've got some data to support that contention. So these are 300 odd men from the watchful waiting arm of that trial. And what you see here is the PSA velocity for each one of them in the first 2 years after diagnosis. And they're divided into two on the basis of those which turned out to be lethal and those which, with long-term follow-up, remained well without metastases on watchful waiting. And what you can see is that their PSA velocities are not very different. I mean, these blobs on the left are higher than the blobs on the right, but there's huge overlap. So you could have a perfectly stable PSA for 2 years and yet still have a lethal cancer. So PSA kinetics are less useful. Here's an illustration of the point that PSA kinetics are less useful. So a man with low-grade prostate cancer went on to surveillance, and this is what happened to his PSA just over 1 year period. So he was having his PSA measured fairly frequently, and over a year it consistently rose, starting at around about 7, ending up around about 13 over 12 months. There weren't major fluctuations. I was seriously worried about this chap. I thought he'd had a really nasty prostate cancer. He finally agreed to have a radical prostatectomy, and he had 0.3 cc's of Gleason 6. Surely completely insignificant. How you explain the PSA, I don't know, but it just illustrates that one can't rely on PSA alone. Now, if you do use PSA kinetics, and I do look at them, I think I would say that PSA velocity is more useful than PSA doubling time. And again, we've got evidence to support that. This is a new paper this year from the Johns Hopkins group of surveillance patients. And what they're comparing here is repeat biopsy results versus PSA kinetics. And if you look over here, this is the PSA doubling time for those men with adverse repeat biopsies and those men with favourable repeat biopsies, absolutely no difference whatsoever in their doubling times. Now, it's not fantastic, but velocity is better. So the guys who had progression on their repeat biopsies did actually have a slightly higher PSA velocity on average compared with those who had stable repeat biopsies. And we've got data in our series that just illustrates the same point. And then thirdly and lastly, in terms of specifics, I do place considerable importance on cancer core length, on the free total PSA ratio, and the PSA density. And this is our data to support that. So based on 416 men in our series, we looked at baseline predictors of who would end up being treated, rather than just carrying the surveillance without treatment. And on multivariate analysis, all these factors turned out to be important. And if you take each factor and you divide men into two groups, adverse and favourable, for each of those 5 factors, then you can get a risk score basing from 0 to 5. 0 if they're all favourable, and 5 if they're all unfavourable. And this is the risk of being treated if you start out on surveillance, depending on the number of those risk factors that you have. And you can see if they're all favourable, none of them have been treated so far. If 4 or 5 of them are unfavourable, there's an 80% chance that you're going to wind up being treated if you start out on surveillance as we do surveillance. And so you might as well have treatment straight away, in my book. And here's a case which perhaps illustrates the same point. So this is our guy who has developed castration-refractory metastatic disease. And he embarked on surveillance 6 years ago with apparently low-risk prostate cancer. He only had 6 cores taken, which was standard at the time, so perhaps that's something. Now, we were very unchoosy at the time as to who went on to surveillance. So we measured his free total PSA, and it was just 9%. We measured his PSA density. It was high at 0.3, PSA of 7.4, gland volume small, 27 cc's. But we still took him on for surveillance because we didn't appreciate the significance at the time. This is his PSA over the year that he was on surveillance, actually from 2004 to 2005. A significant rise, I think, from 7 to 9. And after he'd been on surveillance for a year, then we MRI'd and biopsied him. So again, we weren't doing baseline MRI scans at that time. And his MRI scan after a year showed seminal vesicle involvement. So perhaps if we'd done it sooner, that would have given us the answer. And his repeat biopsies showed high-grade disease. So we had hormones and radiotherapy then, a year after diagnosis, which failed, and he's now on chemotherapy. So if the same man were to walk in through the door today, I would advise him to have treatment on the basis that he had a low free total ratio, a high PSA density. I would also have got a baseline MRI scan, which might have weeded him out. So, those are the three, that's the closest you'll get me to pin my colours to a mast for being specific. But I'm going to end, this is at the end now, with a case. And this is a guy who's been on surveillance, and I want you to decide whether you think he should have treatment now or not. So, he's been on surveillance for 7 years, in fact. When he was diagnosed, he had T1C disease, low grade, 70%, 1 out of 6 calls. PSA of 4, free total PSA of 15%, gland volume of 30, which gives him a PSA density of 0.14, fit and well, no past medical history. He's had no fewer than 4 biopsies, 3 repeat biopsies, which have always only ever shown low-grade disease in a fairly small proportion of the tissue taken, or transrectal. Never had a transperineal biopsy. This is his PSA history over the 7 years. It's gone up from around about 4 to around about 9 over a period of 7 years. And this is his latest MRI. Not sure how well that projects, but I'll tell you what it was reported as showing. It was reported as showing a 12mm tumour in the left peripheral zone there. Now there's nothing unusual about this patient. He was simply a chap I saw in the clinic a couple of days before putting these slides together. This is a summary. He's now 68. He's only ever had low volume, low grade disease. Latest PSA 8.7. PSA velocity of 0.7. PSA doubling time, if you want to know that, 5 years. We've got a 12mm lesion on his MRI, and he's still fit and well, no significant comorbidities. And I'd like you to vote as to how suitable you think he is for treatment. I mean, it's not cut and dried, and I'm not saying it's the right answer, but let's see what you think. Just a gut feeling. If it was your dad, do you think you'd try and encourage him to have treatment? Or would you just leave it up to him to decide? That is excellent. That's exactly what I wanted. Because it just shows you cannot be specific. Who goes for treatment and who doesn't? Because it depends on your opinions, it depends on your values. Some people are more in favour of treatment and more worried about the cancer. Some people are more philosophical and more worried about the treatment side effects. And so what actually happened with this chap is I sat down with him in the clinic and we discussed the pros and cons, we reviewed everything, the PSA, the imaging, the biopsies, and I said to him, I don't have a strong view one way or the other. I think it's quite evenly balanced. What do you think? And together we decided to continue on surveillance, but influenced, I would say, largely by his views. I would very happily have treated him, because I think he was quite borderline in terms of PSA kinetics, MRIs moderately worrying, on the other hand biopsy so far fairly reassuring. So the thing that clinched it was his personality, which is why I'm not entirely specific about a recipe for surveillance. I'll stop there.
Thank you very much, Chris. You nicely demonstrated clinical equipoise at the end there. Now, that was a lovely talk and really throws it right up in the air again, doesn't it? It's not as simple as we would like. It's not always pure science. The patient comes into the equation. Now, we've got just a few minutes before lunch. Any particular questions for Chris? Yes. Lady from Colchester, is it?
Yeah, it's more just to say that that's exactly where the informed decision-making tool comes in, because that's the perfect patient that should be able to make an informed decision with both the CNS and the consultant. That's where the DVD comes in. That's where we're having the DVD in case some people in the room don't know about it.
That's exactly the value of combined clinics with oncologists, so the patient gets the full hit. The nurse is there to talk about the other aspects. And whilst we can all cite evidence to recommend particular treatments, the patient usually at the end of it comes out with a fairly clear view. We've got a line we use in Sheffield. No one could recommend to you the best treatment in the world, but there is a best treatment for you that we will get to. Any other comments? Yes? Claire.
How do you deal with it in terms of, is it only you that speaks to the patient? Because we've all had things you send them to the lady, if you send them to your surgical colleagues, or you send them whatever, they may be swayed by other personalities. Is this a decision that you make with them? And, or do you get them to go and visit the surgeon, visit the...
So in practice, most of these guys who are on surveillance, almost all of them, will just be on surveillance at the Marsden in a clinic staffed by clinical oncologists.
Yeah.
Myself, another consultant, research fellows. So they almost always entirely see clinical oncologists. Having said that, with that last chap there, I offered him the chance to go and see a surgeon to talk about it. So they would often go and see a surgeon when the treatment question rears its head.
He didn't want to upset you though, did he, Chris? Oh no, I trust you not. Because we know whichever specialist the patient sees, they tend to go with that form of treatment.
Yeah, because it's different in our trust, because what happens is, in order for someone to go on to active surveillance, they have to have seen the radiotherapist and they have to have seen the surgeon. And often, because of the various personalities involved, they end up, and with the MDT saying, we would recommend surveillance as the first thing for this patient, as the MDT review. But then they end up coming back to the MDT and actually have decided to have surgery and go, oh my God, Phil, why are they going on to do that?
I should have clarified, they all see a surgeon before they start surveillance.
Right. So
Right, it's 12. Oh, sorry, go on. Final question.
Just wondering, what do you think it's going to take for MRI to become a more readily available part of diagnosis?
Well, I think that we're going to get new data within a few years, and if the data is good enough, then I think practice will have to shift. My hunch is the data will be good. I believe in MRI on the basis of my experience so far, and I'm hoping that the data will support it.
But just to make the point again, Chris, you're talking about MRI before biopsy.
Yes, and I'm talking about multi-parametric MRI.
Yes. Right, 12:30, time for lunch. It's been a fascinating morning. We promise you more of the same this afternoon.